My name is Michael O'Connor, by the way. I'm from the Mayo Clinic. And I'm delighted to have a colleague of mine from Mayo, Dr. Cynthia McCollough, who is Professor of Biomedical Engineering and Medical Physics at Mayo. She is Director of the CT Innovation Centre, and she's also the current President of the AAPM. So she's going to talk about the benefits of low doses of radiation delivered in medical imaging. Cynthia, thank you.
Thanks. Can we have the slides up, please? Okay. I'm actually president-elect. Next year's, it's okay. It seems like there's just as much work. Okay. So I've got, that's my introduction, a few disclosures. So to get started, I would like everyone to turn off their cell phones. I'll wait. I don't mean put it on silent or vibrate. I mean turn it off. I mean turn it off because I care about you. Okay? Because cell phones are dangerous. They give off radiation, and that radiation has been linked, I mean, it's in the news, to cancer. Now, the cell phone growth in the US is amazing. It's exponential. The number of subscribers is approaching the total population. And as of a few years ago, over half of homes had no landlines anymore. So why do we have such exponential growth? Because the benefit is perceived to exceed the risk. Whether the risk is real or imaginary, I'm not going there, regardless of these alarmist media stories, individuals deem their cell phones to be of sufficient benefit to continue this mass migration from landlines to cell phones. But what about public health? If there's even the slightest risk that that cell phone is going to cause cancer, and hundreds of millions of us have cell phones, we could have thousands of Americans dying from cancer. Sound familiar? And in fact, people are out there calculating. I can't read this, it was bad quality on the internet, but like 400,000 brain tumors we expect next year from our cell phones. So we need to reduce risk. Let's go with Alara. Let's buy our headsets with as long as reasonably achievable cables. And power outputs that are as low as reasonably achievable. Forget those drop calls. Or maybe Asara, let's keep our calls as short as reasonably achievable. And we have to protect our children. Landlines for them, no cordless phones, and no walkie-talkies. But all actions have consequences, so okay, it's going to be inconvenient. We're going to go back to payphones in the airports, and it may be longer to get help when your car breaks down or you've got a crash. But some consequences could be life-threatening if you can't get the EMTs there fast enough. So now let's talk about CT scans. Look familiar? Lots of headlines about CT scans causing us cancer. And there's exponential growth in CT imaging. Why is it growing exponentially? Because the benefits exceed the risk. And whether that risk is real or imaginary, which we've been talking a lot about, and regardless of these alarmist media stories, physicians and patients consider the health benefits derived from fast, readily available, definitive medical imaging that CT provides for so many conditions to be of sufficient value to continue using CT at ever-increasing rates. But what about public health? There's this small risk times a whole lot of people. Well, we have some people out there that are very happy to do the math for us and calculate how many people might die because of these large numbers of people, small risks. And so the message that has been given to physicians and patients is reduce the use of CT. Now, all actions have consequences, so think for a minute about your family's medical care. And imagine there was a really big power outage or Florence came through your city and all the hospital CT scanners are gone. They're all down, emergency department, hospital, outpatient, there's no imaging. How would doctors take care of the trauma patients? People in the intensive care unit, surgical complications, how would they treat, plan for radiation oncology patients? Okay? Well, there's consequences if we take away CT. It could be inconvenient. Okay, you wait till things are come back up, you go to the next town. We put in MRs everywhere because they don't have ionizing radiation. You could not keep up with the demand even if you ran all the MR scanners in the US 24/7 because CT scans take about 5 to 10 minutes and MRs take somewhere between 60 and 90 minutes and they're already running extended shifts. Okay, so we're going to delay care. And in stroke patients, for example, time is brain. If you can't figure out if there's a bleed or not in order to administer the clot-busting drugs within a very few hour time window, you can lose the opportunity to help that patient. So CT, the absence of CT, can be life-threatening. And this little guy here, this cute little guy, he is who motivates me to get up here and be on a soapbox for medical imaging. This is Brian Salinas. He fell out of his window, but it was early in the morning and he was up and nobody saw him and no one knew if he lost consciousness, so he goes to the parents take him to the emergency department, but the American Academy of Pediatrics says CT scans are performed only when the child loses consciousness after hitting their head because, and I quote, a CT scan exposes a child to radiation equal to 300 x-rays, and that can require sedation, which is risky. I think they mean the 300 x-rays, but it could be the sedation. These statements came about within the decade after these first alarmist papers about calculating the number of childhood cancers came out. So the doctor says, we don't need a CT scan because we don't think he lost consciousness. And he died a few hours after they sent him home. And I spent about a half hour last night Googling, and I learned about Molly, and I learned about Laura, and Sandra, and a couple other people who all died because their physician did not give them a CT scan in the emergency department. So what is the risk of a CT? Evidently, the population now thinks it's high. Well, we can go to these studies, and they're called original investigations. I take issue with that. There was no dosimetry measured. There were no individuals' case control. They did math. They calculated if we do 70 million CT scans and we go look up what the risk is, we could get 15,000 cancer deaths. And they looked up their data from Beer 7. They go to these tables and they say, okay, we assume how many people, at what age, and they got 10 millisieverts. So we'll just scale down from 100 millisieverts and we'll use this number. And this is what they come up with. So this meeting, we've discussed a lot about what is the magnitude of risk in the low dose range, what's the shape of the curve, what is the variability. We've got all kinds of issues to consider. And the conclusions could be that the risks are small, but not likely zero. They could be small, but likely beneficial. And this is my personal opinion. They are small and not likely ever knowable with any certainty. So let's leave the risk of CT. We can calculate it. We don't really know it, but someone will calculate it for us. Let's talk about how to quantify the benefits of CT so we can talk about the other side of this equation. First way we can quantify benefits is good old medical experience, the practice of medicine, compelling cases that demonstrated life-saving events of CT. This, for those that are not familiar with CT images, is the aorta. And that line going down through the middle of it is a dissection, life-threatening at its highest level. Okay? Quick CT was able to find this. Great case. But does that quantify benefits for us? Well, no, let's get a little more academic about it and publish a case report, okay? It's the same thing, but now we write it up and publish it. So this is a case of someone who slipped, they get the x-ray, and they see something in the x-ray, aha, it's in the neck, we need to go to MR. Go to MR, they took some images, they see something in the spine, they see something here, but they can't tell what it is, so somebody suggests a biopsy. Luckily, somebody else suggested, let's try CT first. And they see there's this kind of hole. I wish I had a mouse to point this out for you. But asymmetries in the body are not usually good. And there's a big hole over there on your right side in the vertebral body. And if they do a CT angiogram, which is what this is, that's where the vertebral artery is, goes up and feeds your brain with blood, which is kind of a good thing. And it takes this very tortuous path and has carved out the bone. This is probably a patient was born this way. A biopsy in this patient would likely have been fatal. Okay, so that's a nice case report. But let's go further. Observational and retrospective studies, where we compare similar cohorts who were cared for using some other modality or algorithm and those who were used with CT, and then we quantify outcomes, cost, quality of life. So there are studies like this. I showed you that aortic dissection, and they looked at the choice and the outcomes, whether you use CT or echo or MRI, et cetera. I want to bring one study to that I think is interesting along this lines. People do these comparisons, but you have to watch out, for the same reason we're all discussing here, about the bias people walk into these studies with. Okay, so this is a study of somebody comes in the CT, nephrolithiasis means kidney stone, okay? Or somebody comes into the ED and they think they have a kidney stone. A couple things can happen. The emergency room attending physician or resident in the middle of the night can grab out their little portable ultrasound and do point-of-care ultrasound, and they can try to figure out what's going on. Or they can send the patient to the radiology, where a trained sonographer can try to figure out what's going on, or they can send to radiology and get a CT. And they said, okay, if we do these different things, does anything bad happen to patients? And they saw that in this study group, there were point estimates that were higher in the point-of-care ultrasound group, but it was not statistically significant. And so I quote, these authors say, this supports the safety of using the point-of-care ultrasound as your first thing that you do, and the majority of the patients were safely spared from radiation exposure. And there we have the bias that went into this study. And if anyone knows the primary author, she took out a full-page ad, and I think it was the New York Times or such, how we're killing ourselves with CTs. But what wasn't, they said it, but what was not emphasized in the news media stories about this, that means about 40% of the one group and 27% of the other group still had to go on and get a CT. So what about their experience? What about the time they waited around in the emergency department still in pain? What about the uncertainty? What about the costs of getting a second exam? Okay, so you have to think about these when you compare one modality to the other. So what other ways can we assess benefit? We can do observational retrospective studies where, and I love this study design, you have the clinician or the surgeon put on paper what they think the diagnosis is and how they're going to manage the patient. They go ahead and get the CT because that's the standard of care. We can't withhold CTs. But they don't show the physician the CT until after they have written down what they think is going on, and then they quantify how often the physician changed their mind. So this was a study done in Boston with all the big hospitals there, Mass General, Brigham and Williams, and they looked at the emergency department because everyone says we're using too many CT scans in the emergency department. And they surveyed the physicians before and after on these different questions. They had about 1,300 patients and 250 physicians. And the leading diagnosis changed 50% of the time in the patients with abdominal pain, 42 and 24% in the other cohorts. The diagnostic confidence, how certain they are that they've got the right answer, was inversely associated with the likelihood of diagnostic change. Okay, so the more certain they are, the more often they were wrong. CT helped confirm or exclude 95% of alternative diagnosis. So 95% of the time, you got the answer even if you were wrong the first time. And about 25% of patients did or didn't have to go to the hospital. That decision changed. So CT made a big impact, and this is a way to quantify it. And if you want to read some of her other papers, she's done this for outpatients, she's done this in young patients, she's very thorough in these analyses. So what else can we do? Prospective blinded randomized trials, those are the gold standard. And when we bring a new application into the medical field, this is what we do. So CT colonography, or coronary calcium screening, lung cancer screening. These are new things that they needed to do these studies so that the government would pay them for them. They had to prove they were useful. So in 2010, the National Lung Screening Trial showed a 20% mortality decrease from lung cancer in smokers who went and had CT screening. In 2012, American Lung Association endorsed this, but everybody kind of hemmed and hawed and said, well, that's not been reproduced. Well, hot off the press, just I think a week or so ago, it was presented the very large European study that they saw a 26% decrease in mortality in males and 39% in females. And individuals who were flagged as having a lung nodule on their screening exam, 41% of the time they did have one. And 69% of the lung cancers that were detected at screening were very early stage, 1A or B. Only 10 to 12% were stage 4. But for the control group who did not get CTs, 50% of the cancers found there were stage 4 when detected. This is going to make a difference. So how else can we quantify benefits? Well, there are just some exams we do that we simply cannot withhold. Trauma patient comes in from a motor vehicle accident. We're not going to hem and haw and try to do a study design, right? They get the CT. So in many cases, we simply have to resort to expert panels and consensus guidelines. So the American College of Radiology has this. You can look at these online. This is data from a few years ago. They update them all the time, but I don't want to keep doing the study I did on this data, so it's a few years old. They have lots of topics and variants, and they take expert panels to look at the publications and know their own experience and come up with guidelines. And the guidelines look something like this: the procedure, a rating, some comments, and the radiation symbol, which I really, really think is the stupidest thing on the planet. So the clinical variation, blunt abdominal trauma, unstable patient, okay. They give a rating scale, 7, 8, 9 is usually appropriate, 1, 2, 3, not. And then they give you your radiation symbol. So 30 to 100 millisieverts gets 5 radiation symbols, folks. That's gonna scare a doc off from doing the exam. So here's blunt abdominal trauma, unstable patient. CT's not so good because they're unstable. They might die on the way to the scanner. But once they're stable, all the top indications say do a CT first. Now, I bring up this picture because it's really pretty pictures, and that's what I like doing in medical imaging. But also for those who aren't in the world of medical imaging, to see the kind of anatomic resolution and detail that CTs can give. And they're used head to toe for just about everything you can imagine. So the guidelines have these tables for just about everything you can imagine. And I picked, I won't show you all of them, but I picked the head because everybody thinks head, you've got to go to MR. Well, I'm glad they have MR. I really am, personal story. I had a brain tumor, it's all good now, but I'm glad they had MR. But look on this scale, head trauma, headache, most of these are 9s, 9s, 9s for CT. Okay, it still has a major role. Abdominal aortic aneurysm, okay, a ballooning out of your aorta, really bad thing. They put these wire meshes on to keep it from blowing up, in which you then bleed to death. You need to measure these quite carefully before the surgeon puts them in so that you don't block the top of the one there. See those 2 little arteries coming off? You don't want that wire mesh going over those 2 arteries, or you shut those off and then their kidneys die. So this is the standard of care if you're going to get one of these. Well, what is the problem with all these papers that count the numbers of people that are going to die, and then the media publishes all these alarming messages? Well, I had a patient, 84-year-old male, who had an aneurysm, was scheduled for CT angiogram right before surgery. One of these papers came out, and all the New York Times and everybody carried it. And he calls and says, "I don't want a CT with that cancer-causing stuff." And there was nothing that I could say to this gentleman to change his mind. And so he went to surgery with an ultrasound, which is just not the same thing. So every time we get one of these media storms, we get canceled patients and worried parents, and it's not good. So to summarize the guidelines, these are just some stats of how often CT is one of the most appropriate and how often it is the single. 25% of the time of all the tools we have, it's the most appropriate exam. So there's data to help you on the benefit question. So we've talked about risk, we've talked about benefits. Should we reduce CT dose or not? Yes, I think we should, but not too much, and I'll show you why in a minute. And I don't think we should because it's going to cause cancer. I think we should because people fear it will cause cancer. And that fear has the negative consequences. the delayed diagnosis, the higher healthcare costs, the emotional distress, the parents calling me in tears because what have they done to their child? Also, CT is so beneficial that it will be used in healthcare, and it will be used again and again, and I want patients to get the care they need. I want physicians to order the exams they need without fear and without worry so they get the care they need. Now, why do I say don't reduce it too much? Because everyone's driving dose as low as they can go. This is a patient that was sent to us. Surgeon says this patient has a pancreatic tumor. I'm sure they have a pancreas tumor from all the indications. Young female, doctor says, let's do thick slices, let's just not do the 2 phases we normally do. And they said, the radiologist said, no, there's no tumor there. Surgeon insisted, there is a tumor there, go back and do it again. So then they said, all right, fine, we will give the proper exam. And sure enough, they saw that it's always easy to read images when there's an arrow pointing out the pathology, but then, of course, they saw the tumors. So if we go too low, we destroy the benefit and we destroy the whole purpose of doing this. So it's all about balancing benefit and risk. Now, the risk could be this big. It could be this big. It could even be on the other side of the equation, and I didn't have a thing I could tip the other way. Maybe it's even a little good for you. But the justification is totally driven by the benefit because it totally swamps anything risk-related. And so once the exam is justified, our job in radiology is to do it as carefully as we can, even if that means going up in dose. So this is really logical. Why is this not working? Dick Vetter, good friend of many of you, gave me this because perception of risk is not logical. This woman is out there smoking a cigarette, and she has complained because those jackhammers in the street construction are going to hurt her unborn baby. Okay? So just some closing thoughts, and I really appreciated Roger McClellan's talk, and I hope I took the notes right, but he said that there are multiple players, those who create the knowledge, synthesize the knowledge, set the standards, and enforce the standards. I think medicine needs somebody else. Medicine needs someone who's going to weight this demonstrated benefit over the unable to be agreed upon small and potentially non-existent risk, who is going to responsibly distill the knowledge into societally responsible methods. And again, I quote him, it's hell to be poor. That's a real risk. Let's do cost-benefit analysis as well and spend money on schools and falling bridges and things like that. So we need societal responsibility and the benefit of the public, and then give clear communication to the public. And so what I personally would like to see as an outcome is a very clear message. I would like this community to help get the message out that medical imaging is safe. Now, yes, it absolutely should be justified, but the bar for ordering should be very low. Remember my little buddy Brian. It should be optimized, absolutely. But ALARA needs to take into account that it has to do the job it's there to do. Remember the pancreas cancer. These caveats are important for the medical providers because they need to be good stewards of resources, they need to order appropriately, they need to perform things safely, and we need the regulations and the accreditations and the quality initiatives to make sure we aren't using adult doses in kids and that we don't use too much in fluoroscopy and give skin burns. The medical community needs all that. The patients don't need to be caught in this big argument. What they need is someone who will do a much better job at giving them this clear message. And so what I hope that more voices will join me in saying is that when medical imaging will provide useful information, get it and don't worry about it. Thank you.